Hello. Thank you for joining us for this presentation, Manage Diabetes Risk and Costs in Your Health Plan, Tangible Ways to Lower Costs While Also Improving Care. This program is part of the SHRM webcast series. You can learn about upcoming and on-demand events from our e-newsletters on the webcast homepage at shrm.org/webcast. SHRM thanks the Diabetes Leadership Council for sponsoring this program and our series of free webcasts for the HR community. Now about today's program. Health experts have declared diabetes a public health crisis. You'll soon hear from medical, policy, and plan experts about the state of diabetes management and prevention, including new innovations in medicines and technology, insurance market dynamics influencing cost and coverage, and tangible plan design features successful companies are implementing today to lower their plan risk and costs while improving employee health. To lead our program, we're pleased to welcome back George Huntley, CEO of the Diabetes Leadership Council. Also with us today is Aaron Turner Pfeiffer, Director, Health Policy with JDRF. I'm now pleased to turn over the webcast microphone to Aaron Turner Pfeiffer.
Thank you, and good afternoon or good morning, everyone. Appreciate you all being here with us. Again, Aaron Turner Pfeiffer, Director of Health Policy at JDRF. Just quickly about JDRF, we're the leading private funder of research focused on type 1 diabetes, advancing cures, therapies, and improving the lives of those living with type 1 today. Our goal and mission is to eventually find a cure for type 1 diabetes. And happy to be partnered here today with George as we talk about all the great ways to improve the lives of those living with both type 1 and type 2 diabetes.
Well, thank you, Aaron, and good afternoon and good morning to those who are on the call today. We thank you for spending an hour with us. My name is George Huntley. I'm the CEO of the Diabetes Leadership Council. I would be remiss without starting to say thank you, Aaron and JDRF, who are actually also a co-sponsor of this, that you didn't get that billing, but we are both co-sponsoring and proud to be so. And it's been a great partnership with the Diabetes Leadership Council and JDRF. I'm a patient living with type 1 diabetes for 40 years. And I'm the CEO of the Diabetes Leadership Council. Everybody on the Diabetes Leadership Council board, we are a policy shop. All of our board members are past national leaders, national officers of a diabetes organization in the United States. So we work on policy for affordable and access to care for patients with diabetes and what they need in order to survive and thrive. And health insurance and this dialogue today is a big part of what we do. In my other day job, I'm the Chief Financial Officer of a professional services firm based in Indianapolis, Indiana. And in that role, I have been the plan administrator of a self-insured health plan, like many of you, for over 25 years. So looking forward to the dialogue today and really appreciate your spending your time. We're going to cover this in different pieces. We're going to start off with the state of diabetes care and coverage. We're going to go through some marketplace dynamics. So by the time we're done, you'll know what diabetes is and how we care for it and what coverage is needed. We'll talk about the marketplace dynamics. And then we're going to have a discussion on plan design, specifically on managing diabetes-related risk and costs. So I'm going to turn this over to Aaron, who will drive us through this, lead us through this first piece of state of diabetes care and coverage, Aaron.
Yes, thank you, George. And I'm going to go over this relatively quickly because I want to make sure we get to our panel of healthcare providers here. But for those who have a keen eye or who are very zoomed in, over my left shoulder here, that is Orlando Brown Jr., who is helping me block the sunlight. His picture, he joined us as a role model. He has a family members who have lived with type 1 or living with type 1 diabetes today. And we recently had our big congressional event for kids and their families with type 1, and he was one of our adult role models. So I'm using him. I wrote the blinds in here, so apologies. But yes, for those Kansas City fans and like myself, Cincinnati Bengals fans, that is Orlando Brown Jr. over my shoulder. So diabetes. As many of you probably already know, diabetes is an epidemic in the United States, but also globally. 1 in 8 adults, 37 million Americans are living with diabetes. Nearly 100 million Americans are living with pre-diabetes. That's the pre-diabetes folks is largely type 2. And, roughly 5 to 10% of folks living with diabetes have type 1. Now, the biggest distinction or the easiest distinction to remember the difference between the two, type 1 is an autoimmune condition, meaning folks can't produce insulin. And type 2 can be autoimmune, but also metabolic, and is defined by insulin deficiency or resistance. Not everyone on type 2 who has type 2 is on insulin, but many folks are. And everyone who has type 1 requires insulin to live. So here just highlighting, really large numbers that you are all are probably aware of. As of today, there is no cure for diabetes, either type 1 or type 2. Now, there have been advancements, especially in the type 1 space, with disease-modifying therapies recently approved in November that delay the onset of type 1. And so we are starting to get into a world where we are potentially delaying the onset and potentially one day curing diabetes. But right now, there's no cure. But individualized diabetes management plans can prevent or delay serious complications. And it's these serious complications that we really see drivers in cost, but also really impact the quality of someone's life. And here I'm just going to go through, you can see them here on the right-hand side. Folks who are 40 years or older, about 1 in 3 of those folks develop diabetic retinopathy. You're 2 to 4 times more likely to die of heart disease. Nearly half of all new kidney failure cases are folks with diabetes, and 60% of non-traumatic amputations are folks with diabetes. And again, I want to underscore these are significant cost drivers, but they fundamentally change folks' quality of life. And so focusing here on these complications, I think, really spotlights the impact that diabetes is having on folks and on the cost of plans. You all already know this. That's why you're here today. Diabetes is a major plan driver around costs. Folks are spending, and insurers are spending roughly 3 times as much on a person with diabetes with complications as they are with a person without complications. And so here really underscores for us in the community the fact that we're spending a lot on complications and not nearly enough on the prevention and management side. And so if we can reduce the expenditures on complications, we can really start to improve the lives. And we can do that through some systematic ways around plan design. And here's a spot that we always want to spend some time and highlight. I'm going to go through this in some detail, so forgive me for that, but I think it's important here to highlight, especially as we're seeing these trends tend to accelerate. Folks of color are disproportionately impacted by diabetes, both in the percentage of folks who are being diagnosed and the outcomes that they're experiencing. I want to highlight here on the left-hand side of your screen the percentage of adults who are being diagnosed. You can see folks non-white, non-Hispanic white folks at the bottom at 7.5%, and really escalating, and the Native American population roughly double the percentage of diagnosed with diabetes. This is in adults. Just highlighting in children, we're also seeing both increased prevalency rates, especially in Black and Hispanic communities. So this is both true in adults and children. And I want to go through here on the right-hand side. If you are a person of color and you have diabetes, you're less likely to get some of the standard benefits and standard of care than your white counterparts, and what this leads to. Let me go through this quickly here. If you're a person of color with diabetes, you're less likely to be prescribed a continuous glucose monitor and an insulin pump. Well, we're going to talk through how important these 2 devices are, but I want to highlight here, these 2 devices are the standard of care for someone with type 1 and someone who requires insulin and is type 2. People of color with diabetes are less likely to receive the appropriate education regarding these devices. They're less likely to have access to these devices due to cost considerations, out-of-pocket cost considerations, particularly relevant to plan design, and they're less likely to be prescribed newer types of insulin or glucagon medications. As a result, not directly or indirectly, folks of color with diabetes are more likely to develop complications. They're more likely to be hospitalized, and what the data has shown over the COVID pandemic, they're more likely to be hospitalized or die due to COVID-19 complications. So all of that builds to here, depending on your view of the world, if you're a glass half full or glass half empty person, there's a room for improvement, opportunities to improve here. In 2020, the CDC noted 16 million ER visits per year. Remember, 37 million people with diabetes, nearly half of that number, 16 million ER visits. And of those 16 million ER visits, roughly half of those were correlated to an inpatient hospital stay. So I don't have to tell you all, the biggest cost driver in our system are ER visits and inpatient hospital stays. Just below these two boxes here, you can see the two boxes on top are the kind of financial impact here. These three boxes on the bottom show that our clinical outcomes were not faring much better, right? So only 50% of folks are meeting their A1C goals. Less than 20% are meeting key factors associated with complications, and nearly 90% of folks are presenting as overweight or obese. So a lot of room here, both on the financial side and the clinical improvement side. Again, these two are linked, but lots of room for improvement here. I think one final note that's important, I think that the community always wants folks to be aware of, is diabetes is largely a self-managed condition, and it's really, really, really hard to manage. And so for those Rent fans out there, you already know there are 525,600 minutes a year. No, I will not sing the song, but just sing it in your head. But of those minutes in a year, a person with diabetes gets roughly less than 2 hours with a healthcare provider. And those are for folks who are lucky and have the time and have the resources and the coverage to access the appropriate healthcare provider. And so a lot of this is being done in a person's free time, carving out time to do it. And, if you have type 1, you're making 180 additional health-related decisions every day. And this is true. We always say if a kid gets diagnosed with type 1, the whole family gets diagnosed with type 1. So if you've got an employee, these 180 decisions are their decisions, right? And through the advent of technology, they're able to, while be at work and their kids at school, actively be engaged in the management of their kids' diabetes. So these are really important perspectives that we just want folks to be aware of, and how you approach your benefit design greatly impacts a person's ability to self-manage their diabetes. So with that, I want to bring in Dr. John Anderson from First Clinic in Nashville, Tennessee, and Donna Ryan, formerly with Ascension Health in Pensacola, Florida, but I recently retired. Congratulations. Thank you. I assume I'm going to live vicariously through you, coming from the beach, straight from the beach, here with us today. And I'm going to be short on intros here, because I want to really get to our discussion, because I know it's so beneficial and impactful. So, Dr. Anderson, I want to start with you, and I think it's always good just to have a level set. Can you just walk us through what's going on in a person's body when they have diabetes?
Right, Aaron, thank you. So diabetes is a disease of energy metabolism. Glucose, or the sugar in the blood, is a key component of nutrition and fuel and energy in the brain, kidneys, liver, muscles, all the organs and all the tissues. And roughly said, diabetes is the inability to use glucose for fuel. We know that glucose sitting in the bloodstream is a toxin. It's a toxin to the very small blood vessels that go to the eyes, the kidney, and the nerve endings of the feet that can lead to those microvascular complications, Aaron, that you said are so expensive. But it also puts a patient at increased risk, as you said, for cardiovascular disease, stroke, heart attack, peripheral vascular disease, amputations. And so what happens is, in people with type 2 diabetes, they have what's called insulin resistance, whether that's due to genetics, age, obesity, or overweight, that doesn't allow them to use insulin very well. And insulin is the key hormone that allows glucose to get out of the bloodstream and go into the target organs where it's used for fuel. And so patients with type 2 diabetes can develop insulin resistance, and their pancreas tries really hard to keep up. And we might find them in what we call a pre-diabetes state, but when they've crossed over into a threshold of diabetes, that means their glucoses are going up in their bloodstream, and they're not able to convert glucose in the tissues for fuel. And as Aaron pointed out, that's about 90% of the patients of the 37 million people in the United States living with diabetes. The other 10% or so are people with type 1 diabetes. They tend to be younger, and they have an autoimmune disease that attacks the beta cells of their pancreas that produce insulin. So they are truly insulin deficient, and as Aaron said, without insulin, they don't live very long. And so it's important to understand the difference between type 1 and type 2, but there's a lot of commonalities. We also know that diabetes, particularly in type 2 diabetes, it's a progressive disease. So as they get older, the longer they live with this disease, the more that their beta cells of the pancreas start to not be able to produce insulin. So many patients with type 2 diabetes, particularly if they had a duration over 10 years, are frequently on some sort of insulin preparation. And so I think it's important to know that that's not common for everyone with diabetes, but many people with diabetes are going to require insulin.
Thank you, Dr. Anderson. I think that's such a good level set kind of about how diabetes is working in the body. And I want to go back to one of the points on the slide. We know that there are some new drugs that have been, in the press and now they're available and on the market. And I just want to highlight this point that, roughly 90% of folks are overweight largely. The drugs and the level of activity around weight has been associated with type 2. So I was just wondering if you could just expand upon that. What role does weight play in the management of diabetes?
There are a lot of factors that go in, particularly type 2 diabetes. Some of it is, as you pointed out, ethnicity. People of color have a higher predisposition to getting diabetes. It's also age. Diabetes, we're living a little longer than we used to, so that's a problem. But the big one that's driving it is the overweight and obesity epidemic. If you look at CDC maps and highlight the areas where there's obesity and then overlay the type 2 diabetes diagnosis, they literally mirror each other. And over the last 20 years, we've become a very obese nation. I live in the southeastern United States in what we call the diabetes belt. And it's because of obesity, it's because of the ethnicity that we have such a burden. And so what we also have to understand is that obesity is a disease. Yes, there are behavioral factors. Yes, there are lifestyle factors that go into it. But once one gains weight to a point that they reach obesity, they have all kinds of hormonal milieu that are keeping them from being able to lose weight. If they lose 5% of their body weight through their own hard effort, the body then wants to not let them lose any more. It will increase hunger and hormones and central nervous system mechanisms to trigger the need to eat. So these patients are really, really fighting their biology. And we can get into this a little bit later when we talk about cost and drivers of cost. And Donna, I'd love to hear your comments as well. But I'm telling you, I've been doing this for 34 years, and we live in an era where the therapeutics, the medications that are now being developed are life-changing. And I'm not using that term lightly, life-changing for our patients. Some of us just got back from the American Diabetes Association scientific sessions in San Diego, and the new data that are coming out with other phase 2A and 2B trials is even more profound than what we have in the marketplace now. So we live in an era where we're starting to have solutions, but our patients need access to them.
No, thank you, Dr. Anderson. I think that's such an important point you've made, and especially adding clarity around this issue of obesity, its relation to diabetes. And I want to actually, no, let's do this now, because I think this is a good point to bring Donna in as well. We had a question around why the disparities exist in the diabetes space. Is it due to lack of education? Is it due to a failure of a particular medical staff? So Dr. Anderson, I think we'll start with you, and then Donna, I want you to jump in here as we kind of roll into this self-management piece. But just curious your thoughts, Dr. Anderson, on that question.
It's a complicated question because it goes to a lot of things. It goes to socioeconomic status, access to healthcare. Are you in a rural area? Until now, we didn't have telehealth. It's hard to get to the physician. You live in a place that's a food desert. Is healthy eating and fresh fruits and vegetables so expensive that it doesn't make sense for your family because of socioeconomic status? There may also be bias in healthcare providers and clinicians. So there's a lot of different things that go into this. The problem is that we can find solutions, and we need to, because those underserved people are getting complications at a rate that is unacceptable.
I agree. And when I read that question, in my head, I just went to yes. It's, there are impacts from and disparities for people of color, and then you add in the geography, as John said, for their performance, for their success in diabetes. We as healthcare professionals, we know the standards of care, and we are on top of that. We're getting the people into our people into the classes, into the doctor's offices, giving them the education to know what to do when their blood sugars are high or low. There are challenges with that, and access is really a challenge when it comes to the cost of care. Back to what you were saying about the cost of care with the ERs and the hospitals. People with complications have higher cost of care. So they're paying for their doctors and their nurses and their medications, they're paying for these healthcare complications. And they simply have a lack of funding and a lack of transportation to get to where they need to go. So we can do better as a society, but in our culture, we need to really focus on making sure everyone has the same access to all of the resources and that they need to control their diabetes. So the answer, again, the general answer is yes. It's all of those. It's all of those confounding factors.
No, and thank you both so much for that. We could spend a whole day, I think, going through this question of disparities, and I'll circle back to it. But I want to highlight a key point here, Donna, that you raised is it's hard. You know, I think that's the number one thing that we hear from the community, that I think the community wants us to reflect back. And it's hard living with diabetes, managing diabetes on a day-to-day basis. Can you just walk us through here? We've got this slide about some of the different factors. Can you just walk us through kind of what we're seeing and what goes into managing diabetes every day?
Yeah, you know, it is hard. There are, it's 24/7, as you said, and there's 42 factors that affect blood glucose. And when you have diabetes, it's a daily juggling act because every day is not the same. No 2 days are the same. Even if you've tried the best of your ability to control all of it, the food that you are eating and the medication you're taking, your activities. There are a lot of variables with how the body processes the food that you eat, the amount of food, the timing of the food, the quality of the food. It's not just about carbohydrates. And then with the medications, making sure that the way the doctor prescribed and the way you understand taking the medications matches your lifestyle and with the food pattern, and that's all being done. That you're doing all that to the best of your ability. You've got exercise. You know, we have teenagers playing basketball, taking insulin. We've got pregnant women that are monitoring their blood sugars very closely and trying to eat right for the baby. There are so many different times during the life cycle that what you did last year, what you did last week doesn't work for this week or the coming days. So we also have the biological, you know, our sleep patterns, our circadian rhythm, our hormones, whether it's your female cycles or your thyroid. You have a lot of different factors that you can't control yourself. So there's a lot to it, and in order to, and going back to that disparity, no matter who you are that you have diabetes. The benefit, a huge benefit, is in working with someone like a diabetes nurse or diabetes dietitian, a certified diabetes care and education specialist, someone who's been trained in the science of diabetes and helps you apply it, the patient apply it to their lifestyle. You can go to Dr. Google, you can read it, you know, pages and pages of what you're supposed to be doing, but until you really understand how your choices affect you and what you can do to control your diabetes. If we don't get that education, then we go back to that loop of the blood sugars are up and down. As you see on the screen, they go up and down. Complications come in. You end up in the ER, or you end up with problems that cost even more time and money to handle.
No, and Donna, I think you said the magic phrase, almost like we've done this before. You said the magic phrase, which queued up, I think, this providing folks with more information allows them to better manage and control their diabetes. So we know there's been a lot of innovative technology around devices that have really come on in recent years to provide and help with that loop and management. So I'm just curious if you could expand upon that, what they are and their impact.
Absolutely. So our ultimate goal with diabetes is to help the blood sugar stay in as normal a range as possible. And we can get there partially with diet, partially with medications, partially, all part of the medical plan and the lifestyle plan that you and your doctor have devised. In order to keep your blood sugars from going too high or too low, we have several technologies now to help a patient know when they're going too high or too low, because it's really hard. I mean, right now, could you tell what your heart rate, can you just intuit what your heart rate, what your blood pressure, what your glucose is? No. The devices of technology that we have for diabetes do that. So we have continuous glucose monitors, and you probably, most people now have seen them on commercials and advertisements. Glucose monitoring started out as years ago as just poking your finger, and you get that finite number at 1, 2, 10 times a day. Now we're able to do glucose monitoring continuously, and these are through devices that give you 288 readings a day of what the blood sugar is, and arrows that tell you if the blood sugars are going high quickly, if they're if they're stable, or if they're going low. That information, especially when you combine it with knowing, with thinking about what you just ate, or if you didn't eat, or if you exercise, gives people the power to understand what their decisions in their daily activities are doing to their blood sugar. So it doesn't take me or the doctor to tell you, well, maybe you should not skip lunch and your sugars wouldn't go so low in the afternoon, or maybe you shouldn't have your French fries and everything else that we like to have in such large amounts. So it's very, I don't know, it's very self-revealing for patients to be able to see what their blood sugars are doing constantly. Everyone, as you said before, on insulin needs, and it's standard of care to have a continuous glucose monitor, and your health plans help you with that to make sure that you have those. We also have insulin pumps, and talking about life-changing, insulin pumps are devices that are attached to the body. They're either with a tube or without a tube. And we set the doctor sets, and the nurse sets the settings in the pump so that the person who's not making enough insulin out of their pancreas is now getting a prescribed amount of insulin constantly, daily, to mimic the healthy pancreas that's working. So we are better able to keep the blood sugars in range, combined with continuous glucose monitor that communicates with the pancreas and tells you on your phone or your device what your blood sugars are doing. Now we have been able to give patients. Now we have been able to give patients I'm so sorry. The technology makes it easier for them to control their blood sugars. I should have turned off my phone. Have you ever done that? I'm sorry. So.
No, we're thinking that must be, is it happy hour, Colin? A beach life? No, but Don, I think I really appreciate that and that perspective. And I want to thank both Don and Dr. Anderson here for joining us. We're going to want to make sure we have time to get into the benefit design piece, but I just want to underscore here what you both have highlighted is that the individual management of diabetes is so important, right. And providing flexibility in your benefit design is so important to make sure that folks working with their providers have all the resources available to them for what works best for them in any given situation. So thank you both. I'm going to let you go and enjoy the rest of your day here as we bring in our first poll question. First poll question of the day. So in a recent study of 571 people with type 2 diabetes, what was the financial impact of using a continuous glucose monitor? Net cost, $424 a month for A. B is net cost of $53 a month. For B, C, net savings of $53 a month. Or D, net savings of $424 per month. We'll give about 30 or 40 seconds here as folks put in their answer. We're going and we're going. And we're going to move right along. So the last chance to get your answer in. All right. Looks like, okay, wow, pretty even split of respondents. Thank you for those who responded. If you answered net savings of $424 a month, you were correct. So the cost reductions were largely driven, and again, underscoring what we've talked about earlier in the presentation, much of these cost reductions were driven by reduced inpatient hospital costs. So again, appropriate benefit design, here, and there's real opportunity if we're giving folks the empowering folks with the tools that they require to manage their diabetes. So real potential here for savings from your plan, but also better quality of life for folks enrolled in your benefit plans. So with that, I want to pull George back in here as we get into some of the market dynamics around the cost.
Thank you, Aaron, and thanks also to John and Donna for your participation and sharing your insight into this issue of diabetes. It's really appreciate the focus on that today. So thanks, Aaron, very much. So I'm going to take us through some of the things going on in the diabetes in the health plan marketplace that's causing prices to rise, and things that to make sure that everybody understands where some things are happening. We've all heard about the massive increases in the cost of insulin. That's been in the news. Everybody knows and sees it. But this slide, I think, gives you a picture's worth 1,000 words. Over the last decade, the list price of insulin has gone up 143%. That's a huge increase on a drug that's been out there for a number of years. But what people don't really know is over that same decade, the actual net cost that an insurance plan is paying for that drug has been cut more than in half. So during that period, while you would think, oh, there's competition, time is going on, the cost actually got cut in half, but the list price went through the roof. And this difference here that you're seeing here is the rebate. It's the rebate that is being charged by the pharmacy benefit manager for access to the plan formulary. In the case of insulin, that rebate is 70% or even more in some instances. It's on average 48% for any brand drug. So that's a cost, and I'm going to move us on here, that the pharmaceutical company is paying to the pharmacy benefit manager for the access to the plan, for the access to the plan formulary, because without access to the formulary, the pharmaceutical company has no place to sell the drugs, because you have to it's got to be covered under the insurance plans. So these negotiations to get access to the formulary are big money. The top three pharmacy benefit managers, which are, I'm going to go back and forth here for a second. So the top three pharmacy benefit managers, Optum Rx, CVS Caremark, and Express Scripts, they have about 87% of the U.S. marketplace, well over 80% of the U.S. drug marketplace. So these negotiations are, they are for access to a big swath of the market. They are also owned by insurance companies, so it's all in the corporate family. So when I go back to this slide and talk about who the players are, you've got your employees, your plan participants in January are going to the pharmacy to pick up some insulin. And I'm hoping at this point that you've exempted insulin from the deductible, but if you haven't done that, they're buying a vial of insulin for roughly $300 to just use round numbers. Pharmacy's probably keeping 25 of that and sending $275 down to the drug company. The drug company is keeping about 50 of that $275, and they're sending $225 over to the PBM. Now, I'm going to say that again, just in case you didn't follow. Your employee spent $300 for a vial of insulin, and $225 of their money wound up over here in the left-hand corner of this slide at the pharmacy benefit manager. And the pharmacy benefit manager now has this money that your employee spent during their deductible period, and they're going to keep a piece of it, anecdotally 10%. We know in the state of Texas, isn't that 10 to 13% in other cases, and it depends upon your individual negotiation with them. They will then send the rest of it back up to the insurance company or the health plan in a self-insured health employer-based plan like the one I administer. So that money is going up to your company if you're self-insured. So again, your person has just spent $225 and they've basically put money in the kitty. And the insurance company or the health plan, you as the employer, you're saying, I'm going to keep the premiums down for everybody else. By the way, your employee just paid a premium for access to the club, and you didn't give them any of the discounts. You didn't give them the net price that you pay. You made them pay the 143%. So now they have put money in the kitty. So you now have their money helping keep everybody else's premiums down. You have the sick subsidizing the healthy, which is not how insurance is supposed to work. Insurance is where the many pay the costs of the unfortunate few. But in health plan design, and specifically with pharmaceuticals, that's what's happening today in many, if not the vast majority of health plans, if we're not passing through rebates at point of sale. So that's the dynamics of what's happening here. And the consumer, by the way, in insulin, you need 3 or 4 vials, or sometimes 5, depending on your level of insulin resistance, in a month. So it's a lot more money than just the $300 I was speaking of. It's real money. We've already covered that they own each other, and it's been all one corporate family with the specialty pharmacies. They're all sending you, if you're in Aetna, chances are you've got to go to CVS. If you're in one of the others, you may have to go to Walgreens. It's not which one do you want to go to, which one's convenient for your people. It's which ones do they make more money off of by sending your people to their place. As I mentioned, these rebates are on every branded drug out there. So the average is 48%. So if you're not passing rebates through, you're literally double charging your people for their drugs during the deductible period. Obviously, once the deductible's met, they're on a copay. And one of the questions that almost always comes up is, George, what's this going to cost? If I pass through rebates at point of sale, we're never going to afford it. It's going to drive up premiums. Cats and dogs are going to live together. It's going to be just absolute chaos. And I hear that from a lot of people. And the good news is it's not true. It's really almost zero impact on the overall cost of a plan. The first thing to note here is nobody is buying drug insurance. You as an employer are not providing drug insurance. You are providing health insurance. And your cost for that health insurance is the holistic cost of the plan. So the overall economic impact of it is about less than 1% of increase in total plan costs if you pass rebates through at point of sale. Very importantly to note, that study does not reflect the fact that you're going to have healthier patients on your plan. I would submit you are likely to save money by passing rebates through at point of sale. We're going to talk a little bit more about that in the next slide. But here you have an actuarial report showing that this is almost nothing. And if you think about drugs in a health plan, it's 10 to 15% of a health plan's cost. Yours might be a little bit larger, but if it is larger, it's being driven by specialty drugs. If you look at the drug plan, specialty drugs are usually more than half of the costs. They don't have big rebates aren't really an issue on specialty drugs, nor are rebates an issue on generic drugs, which is about 20% of a drug plan. It's really only in those branded drugs that the rebates are coming into play here. And so you're looking at about 30% of a drug plan, maybe 3% of an overall plan. And you're only talking about passing them through at point of sale during the deductible period. Once they've gone past their deductible, those rebates flow through to the company as they ought. And you are using those to keep everybody's premiums down. That is lowering the overall cost. But during the deductible, you're in a scenario of some false economics, because one thing you know or should know about a patient with a chronic disease, and specifically with diabetes, is we're going to meet our deductible 100% of the time. It's not an if, it's a when. So if you overcharge a patient or one of your plan participants for their drugs, congratulations, you are going to pay another claim that you otherwise would not have paid. So you are just robbed Peter to pay Paul. There's zero impact on your plan, but you've made that participant far more likely to ration their medications, far more likely to be non-adherent to their therapy by the inadvertent dynamic of these rebates and not passing them through to the people at point of sale. And we know benefit structure determines access. This shouldn't shock anybody, but these are 4 very real scenarios in today's plans. And this is insulin, but the math works for anything. If your first dollar preventive coverage, chances are people are going to take their drugs. At $25 a month, chances are you're fine. If you're passing rebates through on insulin, they need so many vials, they're still paying $360. If you're not passing it through, many people have a comma in January. And we know that 69% of patients will abandon the prescription if the cost is over $250. Now, a patient with type 1 diabetes is not going to abandon the insulin because they need it to live, but they are going to ration it. And we know 1 in 4, in fact, are rationing it. And bad health outcomes when you get there. Is the rebate is discussing only on self-funded plans? No, it's on any plan. You can, the plan design, if in a fully insured plan, you can talk to them about whether your people are getting access or the negotiated amounts at point of sale. That's something you can talk about. You've got much more control in a self-funded plan, absolutely. But all of the pharmacy benefit managers will pass it through. You do have to discuss it. I'm going to shift this to a quick poll question because we're going to run fast here. Does your organization, do you know if you offer at least one plan with full rebate pass through? Some of you may not know. Some of you may be doing it. My company is doing it, so one of us is. But would urge you to spend a second and share where your plan is today. Starting to get some answers in here. Great, thank you very much. So let's see where we came up, and I really appreciate, so this is about what I expected. 7%, little under 10 are actually passing it through. 30%, 29, no, we're not, and 63% really aren't sure. Urge you to take a look. Urge you to take a look. This is a tangible thing you can do for your employees that will not cost you and will actually save you money in the long run. PBM incentive, these perverse incentives that the pharmacy benefit managers have to put the highest priced drug on your plan. I want a couple of things to point out, because if you're not focused on it, you don't realize it's happening. Let's just take the middle. These on the left-hand column are the primary insulins out there, the most common insulins out there. And there's a lot more out there today now. Novolog, just to pick on them, all three of these in the middle are made by the same company. They're Novo Nordisk's Novolog. Same insulin manufacturing plant, same insulin going into the same vial, but they slap a different label on it, brand it differently so they can price it differently, because nobody is picking up Relion on your formulary because there's not enough money for rebates to go to the pharmacy benefit manager. So the lower cost drug isn't on your formulary, the high cost drug is on your formulary. If you're not passing it through at point of sale to your people, you're forcing them to pay for the high cost drug when the low cost drug actually is out there and exists. But on what planet does it make sense for a manufacturer to create a generic of their own product? That never happens. Nowhere else in life does that happen. It only happens in pharmaceuticals because of how these rebates are happening, and the manufacturers had to do it in order to offer their drug at a lower cost for patients who were desperately in need of it. You look at generics and biosimilars, the lowest cost drug doesn't always win. This is Medicare Part D data, but it's the same 3 PBMs that are driving this. So it's the same folks you guys are using. Only 1 in 4 new generics are landing on a health plan in the first year. You'd think a new generic is offered, hallelujah, welcome to the party, let's put you on the plan immediately. Not happening, because they don't want you to have your people not take the branded drug with the rebate. Less than half of generic products today are actually on that generic tier on your health plan. Check your health plans. I wish I were lying to you, but I'm not. Less than half are landing there. So your patients, your participants, your employees have no incentive to take the low-cost drug versus the branded drug. And that's what they want. And that drop has plummeted over the years. But again, when your employees are in their deductible period, they don't have access to that low-cost drug. So you're forcing them to buy the high-cost drug or buy it outside of your plan. Touching very quickly on obesity drugs here, we've mentioned that these things, the drugs that are now coming onto the market have much greater efficacy. It's amazing what's out there today. Lifestyle management alone doesn't work. Urge you to take a look at these. These drugs are not inexpensive. I'm not here to say that they're inexpensive. I am here to say that they work and that the patients ultimately need access to them. We as employers can work on reducing the stigma of obesity and the stigma of type 2 diabetes. And as you're thinking about when to cover these medications, let's bear in mind it is not the patient's fault that they are dealing with a chronic disease. Nobody asks for a chronic disease. This is the way it is. Urge you to take a look at your health plans and in covering these. Most are following Medicare Part D, and Congress, when they enacted it, forbade themselves from covering a weight loss medication because there wasn't anything in 2006. Not so in 2023, and we're working on changing the federal law on that. Urge you to take a look at that. Investing in diabetes management does pay off. We have Express Scripts talking about, this is last summer, capping the cost for all diabetes medications, not just insulin, at $25 a month. So bypass the deductible. You're going to lower your entire medical costs for diabetes by 16.3%. That is a big savings overall. Again, the savings is happening on the major medical side. It's the hospitalizations that are driving this. You're trying to look at your overall health plan, not a silo of a drug or a device or major med. It's the holistic plan. And urge you to look at these things to avoid the rationing, to avoid the complications. We're spending money on complications. We're not spending money on treating or enough money on the management of the disease itself. A very quick new poll, and hopefully you're staying along and playing along at home. Does your health plan offer first dollar coverage for diabetes management? This is exempting them from the deductible. You are allowed to do that in a high deductible health plan today. You can exempt chronic disease management from your deductible. Are you doing that, or are you making your plan participants pay for their insulin prior to the deductible, pay for your other meds? Do you have a program in place that allows all of that to happen pre-deductible? Hopefully, with the last slide about Ben Franklin talking about what you can save if you do that, hopefully we can get you thinking about what you could actually be saving if you look at your diabetes costs on the plan, what you could be savings if you actually looked at that health plan design and made it more proactive. I'm going to move us forward here. So less than 20% are looking at first dollar coverage. The good news is not quite 20%, 17% are already doing this. 48% no, you're not, and I urge you to think about it. And 35% aren't sure. All of us have these things memorized in our heads from a plan design perspective. But this is an opportunity to improve the care and improve the lives of your people, and again, also save you money because the driver of diabetes costs are in the hospitalizations, it's in the heart attacks, the strokes, the end-stage renal disease, the blindness that is causing these things, and the hospitalizations, as I mentioned. That's where the money is, and that's what you're really trying to fight and avoid. So I urge you to think of this. Thank you for playing along. And we are moving fast here, and the time is going by. And I really want to invite my friend Rich Musti to join us here to have a quick conversation on employer plan designs. And Rich, I hope you can turn your camera on and we can go into a conversation here. Thank you. So Rich is the co-founder of Unified Group Services, located in Anderson, Indiana. And in full disclosure, Theoris, the company that I'm the CFO of, I've worked with Rich for a number of years. So he and I work together closely. Rich is a licensed insurance agent, a member of the Society of Professional Benefit Administrators and the National Association of Health Underwriters, which is now the National Association of Benefits and Insurance Professionals. UGS is a full-service third-party administrator for self-funded group health plans. And so I've worked with him for a number of years. You've got over 125 employees on your own. And I'm going to let you tell the audience a bit about UGS and about the types of employers you service, to your client base, so that you get a sense of who you're dealing with, and when we talk about things, where your team's looking at.
Okay, George, our typical customer, and as you said, we're in the full-fledged administration, self-insured business. Medical and always RX is coupled right there with that, a huge part of the conversation and services we provide. Typically, the customers that we have are those that you mentioned, the big carriers. Is absolutely our competition, and they're very interested in our ability to customize and get them away from the big box effect, and be able to tear their plan apart and really look at all pieces to manage that to the lowest cost, and particularly bring that to the patient, which I take great pride in. So our average group has probably a couple hundred employees, but that's that middle market sector that's all self-insured. We handle 70,000 plus people in multiple states, so we've got a nice array of customer base that makes us viable across all industries, actually. So it doesn't matter what kind of group they are, as long as they want to self-insure and have custom health plans. That's what we do.
So, middle market, middle America, from a self-insured perspective, you've been, my company's been in that size frame for a number of years, and I'm sure many of our audience participants are as well, and there are probably some larger players too. We've always been passing rebates through to our employees at point of sale. You've been an advocate for that, and I know you've done that for your clients. Talk to us a little bit about what was your driver for doing that, and what were the barriers, if any?
The barriers were, George, way back in the day, and we've been doing this for pushing 17, 18 years now. The barrier was PBMs that were participating in that, because their lifeblood has been the sharing of rebates or keeping the rebates. So we're able to hook up with some of the more transparent and/or totally transparent PBMs, and across our board, I would say 90% of our customers pass along rebates at point of sale. The plans aren't interested in them getting the rebate; they're interested in the employee, the participant, getting rebates at point of sale. And I like to use a fresh, really good example, because I think sometimes the rebate conversation seems far removed from people being able to understand. But to bring this into light on a today's basis, Ozempic, can't think of any drug that's more popular right now and/or in greater conversation. And our plans, the plan cost at point of sale is $827, but the actual rebate on that is coming in at $345. So that plan participant's paying $482 at point of sale. If they owe, pick a number, $100, they pay their $100, and then the plan owes the other $382. Nobody's waiting on rebates. It's delivered at point of sale, and it's been very, very successful for us. The participants love knowing that they're getting the lowest cost prescriptions possible. We're not driving them to CVS or Caremark to drive up the rebate and play the rebate game. But if rebates come into play, we know we're getting those deployed at point of sale.
Yeah, and they're getting the value. They're paying a premium to get access to the club. The analogy I always say is you're paying a Sam's Club dues, and you're not getting Sam's Club pricing unless you're doing exactly what you just described.
Yeah, and a quick comment, George, I'd make with that. We look very introspectively at what we're doing with our customers across the board to make sure we're keeping relevant and delivering value. And on our whole book of business, 70,000+ lives, our net medical trend, I should say our net prescription trend this past year was -3%. So I know that the rebates at point of sale, we have a lot of plans that's doing what you guys are proposing and makes sense to get diabetics their drugs for free or lower copays and limit their out-of-pockets. And it's showing on the bottom line to have a -3 prescription trend is, I'm proud as heck of our efforts with our customers.
Yeah, that's a great number. So we've got a question in here, Rich. If I understand the presentation correctly, the cards are stacked in favor of the PBMs and not in favor of the plan participants. True. How can we change this, since I don't see a viable option where you can have a pharmacy benefit without a PBM? And they're correct. You need a PBM. That function is required. My view is you can negotiate with them. You can work with them, treat them like a vendor. There are more than just those three out there if you want to go through. So really quickly, because we're running short, what would your advice be?
I would say, George, and it's maybe an exhausting list, not a great word to say, but exhausting list of PBMs out there, but through proper benefit brokers and advisors that we get business through, and then our connection to the industry, quite frankly, staying away from those large and robust in size PBMs. There's a lot more boutique and or smaller PBMs yet have the size by their banding of purchasing groups that bring great price and extreme value and total transparency in their contract, because those big ones, they've played the game for so many years, you can't hardly outsmart them. But the other, the smaller, that maybe it's names that people haven't heard of, we're seeing great performance out of them, and they continue to grow. I mean, I'm working with one that happens to be based in Indiana, but my gosh, they've grown probably 200% in the last 2 years, and that's taken business away from those big names that are out there by delivering extreme customization and ultimately low cost.
And they're asking, I got a question in here, do the smaller ones rent the networks, for want of a better term, from the larger PBMs? Or are they doing their own networks? Doing their own networks or their consortium, right. But it is definitely not piggybacking off of those big guys, without question. Yeah, from a negotiations perspective. Right. There's another question. Can an employer contract directly with compounding pharmacies to reduce costs? I'm not sure I'm going to suggest that, because there's a lot of things from a safety perspective that you may get in there, but I don't know if you've had anybody run across that. Not fair to answer that, because I'd have to dig into that. I don't know if that's taken place. But yeah. These smaller PBMs, and to me, small, it isn't bad. They've got hundreds of thousands of lives. Maybe they don't have millions, but they certainly play very strongly in that market, and I'm sure they do a lot of things on those compounded drugs and make it cost competitive. Yeah, absolutely. There's a question I want to take here. By exempting the diabetes management from first dollar plan deductibles, would that not cause concern that would drive up the upfront cost for the diabetic and possibly cause them to not manage their disease? I just want to be clear. No, the point here is actually it drives the cost down for the patient. If you exempt it from the deductible, they're going right to a copay. So they're paying $20, $25 instead of the full cost of the drug or the full cost of that device, that sensor. So you're actually making it far more affordable for your employee, making them much more likely to adhere to therapy. That's the whole point of that. So the question came, so I needed to make sure we addressed it. You're going to wind up with much greater adherence to therapy if you bypass the deductible and go right into coverage with a copay with diabetes management. I urge everybody to really take a look at that. Rich, we are so out of time, and sure. I'm sorry about that, but I really appreciate your being here. We've got some things on our website that you can download, some additional plan design features to think about, covering telehealth that came out, covering diabetes education, making sure you've got a rapid approval process, especially you get these prior authorization scenarios. People today are on a plan for 3 to 5 years. You're with an employer for a short period of time. You and I, Rich, are dinosaurs, pun intended, because I've been with my company 20 years, but we're not the norm, right? People are changing their jobs. So if you've got somebody joining your plan and they're not 20. They're in the middle of their career. They've been living with a chronic disease, let's pretend diabetes, for 15 years, and you suddenly make them go backwards and do step therapy and fail on all the things that you know that the doctor and they have been failing and dealing with. It makes no sense to go backwards on step therapy. Look at your plan design, and if you have step therapy, make darn sure you've got a grandfathering ability on step therapy. I'm going to take us to a final poll, and thank you all very much. After viewing this webcast, are you more likely to consider passing rebates through? Is this now on your radar at point of sale? And I would welcome the audience to take a look at this. I'm hoping that you've learned something through this conversation, and I know we're past the top of the hour, so I'm moving really fast. But I again appreciate if people would plug in there. It might be a softball question, but I appreciate your answering it. And Rich, thank you again very much. I appreciate it so much.
Thanks, George. Anybody needs to reach out to me, feel free to do so. Love to help. Thank you.
Awesome. We have not found using smaller PBMs limits the access to specific drugs. In fact, I will say with a smaller PBM, I actually have more control because I actually tell them, and through Rich, what I want covered. If I wind up with an employee coming saying, hey, this isn't covered, and if we look at it and say, okay, well, that makes sense to get covered, I can actually override it. As a self-insured employer, you have a lot of power. If you're buying fully insured products, you have a lot less power. But as long as I'm not approving something that's going to get my catastrophic claim insurer at risk, you're going to be that catastrophic claim insurer actually applauds me covering that extra drug, because they take the drug, they're less likely to have the hospitalization, the thing that is going to cause a six-figure claim that insurer wants to make sure doesn't happen. Well, 88%, thank you very much, said yes, you consider it. 4.6 haven't been swayed yet. And again, the 6.9 are already doing it, and I respect that as well, of course, and thank you. Guys, it has been a pleasure having you guys be on this. I hope you've learned something today, and there's some takeaways from you. We could go for hours on this, and happy to. Some great questions are being put in here. What are the pros and cons of when you carved out from the health plan? What are self-insure? We are self as our PBM. Yeah, you pass along a rebate to us. You really need to be talking. If you're not getting a rebate passed through to you, you've got a problem. And that is you need to treat everybody in that scenario as your vendor. They are your vendor. You need to manage your vendor. They have a service. If they don't provide that service, someone else will. So we, again, really appreciate this. I want to thank our partners, JDRF, who are also co-sponsoring this. I'm sorry their logo is not on here, but they deserve to have their logo on here. And Aaron, thank you so much for being part of this and helping us, for years on this program. We've really appreciated it.
All right. Thank you. This program is sponsored by the Diabetes Leadership Council. The Diabetes Leadership Council is a patient advocacy organization whose members are individuals with decades of diabetes experience and leadership who work to advance patients' first policies related to diabetes at the local, state, and national levels by engaging policymakers and public and private sector influencers. JDRF is leading the fight against type 1 diabetes by funding cures research, advocating for policies that accelerate access to new therapies, and providing a support network for millions of people around the world impacted by type 1 diabetes. Both organizations are working to educate employers on health plan design options that lower their plan risk and costs while improving employee health. For more information, please visit diabetesleadership.org and jdrf.org. Before we sign off, we want to thank our presenters, George Huntley with the Diabetes Leadership Council, Donna Ryan, Dr. John Anderson with First Clinic in Nashville, Aaron Turner Pfeiffer with JDRF, and Rich Musti with United Group Services for the information they provided today. And we also want to thank everyone tuning in for being with us and for choosing SHRM for HR webcast. That concludes this program.